I'm going to present a case of a 6-year-old male. He has common cell carcinoma of the glottis. He presented to emergency room on 14th of December with the complaints of cough for 2 weeks, left-sided chest pain for 1 week, and shortness of breath for 2 days. So my patient was in usual state of health 2 weeks back when he started experiencing cough. Cough was gradual in onset. It was progressive. It was productive with whitish sputum. Sputum was scanty in amount, and there was no hemoptysis. So he also was having chest pain. Chest pain was localized to the left anterior side of the chest. It aggravated with the posture. It was more on leaning forward as well as lying down, and it was sharp in nature. It relieved to some extent by some analgesic. He was also experiencing chest pain on the lateral part of his left chest, and that was dull in nature and aggravated with cough and sneezing. He started experiencing shortness of breath that was gradual in onset. It was exertional. It was progressive in nature. It progressed over a period of 3 days to an extent that the patient was short of breath even in the sitting position. His systemic review at the time of presentation was unremarkable for any significant findings. Regarding his past medical history, as I already mentioned, he has common cell carcinoma of the glottis diagnosed 2 years back. He was given first cycle of chemotherapy in September 2022. Percutaneous endoscopic gastrostomy tube was inserted in September 2022, and radiation to the glottis tumor was given in October 2022. Other than that, there was no other medical or surgical history. He was not allergic to any drugs. And regarding his socioeconomic and personal history, he was a shopkeeper and he was an ex-smoker with a history of 10-pack years smoking. Other than that, there was no addiction or habits. He had no sick contact. He had no recent travel, no pets at home, and he used to take pasteurized milk. So on the first ER visit, his vitals were blood pressure was 118 per 88 mm of mercury. His pulse was 108 beats per minute. Temperature was 37 degrees Celsius, respiratory rate was 18, and his saturation was 90% at room air. On general physical examination, no significant findings like cyanosis, clubbing, lymph nodes, or peripheral edema could be appreciated. On initial chest examination, there was reduced movement on the left side of the chest. Percussion note was dull, and there were few freckles in the mid-chest which were audible at that time, and absent breath sound was present at the left lower zone of the chest. In cardiovascular examination, there were no added sounds, no murmur or pericardial rub that was audible. His neurological examination was unremarkable, and in his GI examination, only significant finding was PEG tube in place, and that was also, there was no infection in that area. So in summary, our patient is a 66-year-old male, ex-smoker, squamous cell carcinoma of the glottis, status post-chemotherapy and radiotherapy, and presented with a 2-week history of productive cough with whitish sputum, chest pain localized to the anterior part as well as the lateral part of the chest, and associated shortness of breath. On examination, crackles in the left mid-side of the mid-chest as well as absent breath sounds on the left lower zone of the chest. So based on the history and physical examination, anyone want to comment on the differential diagnosis? Any fellow from ID department can comment on differential diagnosis? Yes, please, Mr. Hassan, you have raised the hand. So yes, we have a comment in the chat box, and it says that it is pneumocystic carni, left-sided pleural pain could be secondary to MED. Definitely, it can be TB, definitely, and PCP pneumonia, aspergilloma. Yes. Any other comments? So let's proceed to the investigation. His WBC count was raised with predominant neutrophils. 13,800 was the WBC count with 92% neutrophils. His hemoglobin was 11.5 gram per deciliter. Platelets were in normal range. His initial RFT, LFT were normal, and electrolytes were also normal on initial presentation. So this was his chest X-ray on the first encounter in EER. So we can appreciate some kind of haziness as well as the blunting of the angle in the left lower part of the chest. So this is the ECG of our patient. Anyone can comment on this ECG? What are the significant findings in the ECG? So anyone would like to comment on the ECG, please? Yes, tachycardia is there. Any other significant finding? Sorry, you're not audible.
You can type your messages, everyone.
Sorry?
Diffuse
ST elevation and depressed PR interval. Yes, Dr. Ramla, exactly. So we can appreciate there is diffuse ST elevation in all the chest as well as the limb leads, and there is significant PR depression, which can be seen in the ECG of the patient, and it is quite significant for pericarditis. So this X-ray and this ECG, up till now, we have the positive findings of this ECG and X-ray. We did an echocardiography on the very next day, and ejection fraction was normal. There was no pericardial effusion seen in the echocardiography. His trough was normal. His CRP was raised 531.9 milligram per deciliter. His D-dimer was a little bit raised, and his viral markers were negative. So this is the first ECG, CT scan of the chest of our patient. It was done on 14th of December. So can anyone comment on the finding of this CT scan? Sorry, yes. Any comment on the axial slices, sagittal slices, coronal slices?
Yeah.
Any comment, please?
Fellows from any of the centers can please comment, and could you tell us what you see on the CT scan?
Multi-lobulated effusion, Kurathulan, yes. Loculated effusion, exactly. Any other significant finding, if you can appreciate on this mediastinal window, if anyone can comment, because the patient was also having pericarditis on ECG. So any other finding other than loculated effusion? Effusion and a mass. Dr. Hassan, where can you see the mass? Can you please point out? Pericardial enhancement. Yes, pericardial thickness is definitely visible in this slide. So up till now, we have the significant findings of loculated pericardial, pleural effusion. We can appreciate pleural effusion in the subpleural area, in the periphyseal area, and this effusion is also extending in this area. In the mediastinal window, we can appreciate pericardial thickness, and the normal pericardium is almost 2 millimeter thick, but here the radiologist reported it to be 7 mm. In the sagittal views, we can also appreciate here the pericardial thickness, and we can also appreciate the pleural effusion, the peripheral one, and the subpleural effusion in the coronal as well as the sagittal area. So the radiologist reported it to be the loculated peripheral and subpleural effusion seen in the left lung with underlying atelectatic changes. Mild pleural and pericardial thickening was also noted, and the study was negative for pulmonary embolism. So now, can you please comment on the differential diagnosis? So the patient has loculated pleural effusion, patient has pericarditis as well as pericardial thickness, and patient has a history of cough, chest pain for 2 weeks associated with the shortness of breath. So now, can you comment on the differential diagnosis, please? So any fellow? Tuberculosis. Yes, tuberculosis can cause loculated effusion as well as it can involve pericardium and it can cause pericarditis as well. Any other differential, please? TB metastasis, definitely he had a carcinoma of Clotes, so metastasis would be one differential. What are the infective causes of effusion as well as pericarditis? First, we can comment on that, then we'll go for the non-infective causes. Any other differential for pericardial effusion, pericarditis and pleural effusion? Infective causes of pericarditis and effusions. So other than TB and metastasis, can anyone comment? Any fellow from AKU, any fellow metastatic salmonella infection or brucellosis? Yes. Any other differential you can think of? Staph aureus, yes, it comes into the bacterial causes of, it is one of the causes of pneumonia as well as pericarditis. What else? Let's think about something rare, which we usually do not see in daily basis. Coxsackie virus, schistosomiasis, and fungal infections. Yeah, but the patient had a history of almost 2 weeks, and yes, nocardia. Anything else? So let's move forward. So these are the infectious causes of pleural effusion, bacterial pneumonias, and there's quite a list of bacteria which can cause, which can involve lung as well as pericardium, mycobacterial infections, fungal infections, and the viral infections. And there are some non-infectious causes of pleural effusion and pericarditis, like radiation injury, autoimmune disorders. Drugs can lead to both of these disorders, uremia and malignancy. So we started the patient on piperacillin, tazobactam, azithromycin, and with the help of cardiologists, we started him on NSAIDs because of his pericardial pain, because he was experiencing pericarditis, and he was also given oxygen via nasal cannula. We planned pleural tap on 18th of December. 100 ml of purulent fluid was removed from the chest cavity, and it was sent for analysis. And there were 16,780 WBCs, in which there were predominantly neutrophilic infiltrate were there. RBCs were 790 per microliter, and the protein was raised and LDH was raised, and it was an exudative effusion. And TB gene expert was done, and it was not detected at that time. So we did send a sputum culture, and sputum of the patient showed Pseudomonas aeruginosa, and it was quite sensitive organism. And also, it also had Staph aureus, and it was MSSA, methicillin sensitive Staph aureus. So the pleural tap from the patient, we grew this on the blood agar, and this was the colony which we got after 3 to 5 days. So can anyone comment on the colony? So azithro was given because the patient presented from the community, and we were thinking of some community acquired and atypical infection. So azithro was started for that reason. So what about this culture plate? Okay, H influenza. No. What kind of organism give this kind of colony on the culture plate? Chalky white colony. Yes, it's nocardia. Yes. Very good, nocardia. Yes. So this is the gram stain of the pleural tap, and there was branching organism seen. It had a beaded appearance on the gram stain. So it was, we did a mass spectrometry examination, and it was nocardia seriously georgica. So what is the treatment now? So if now we have diagnosed the patient with nocardia, so what you are going to change in the regimen? What should be started and what should be stopped? Anyone can comment. So do you like to change the regimen because we were giving piperacillin, tazobactam, and azithromycin to the patient? Amikacin, ceftriaxone, linezolid, yes. Trimethoprim sulfamethoxazole, yes. So we did start our patient on trimethoprim sulfamethoxazole. Piperacillin, tazobactam was switched to ciprofloxacin to cover the Pseudomonas and the MSSA in the sputum to complete 14 days of treatment, and the co-trimoxazole was added on 22nd of December. And we planned a repeat chest X-ray and MRI of the brain. So this was the repeat chest X-ray of the patient on 26th of December. So we can see that the effusion is quite large as compared to the one which was done on 14th of December. So we started him on imipenem. We added imipenem and celastin in our regimen along with cotrimoxazole, and chest drain was placed and 2 liters of purulent fluid was removed from the chest, and again it grew nocardia. So this was the MRI of the brain. MRI showed a lesion in the posterior part of the left parietal lobe, but radiologist suggested that this is old insult to the brain. It can be a gliosis. It is less likely to be an abscess because there was no diffuse restriction and post-contrast enhancement was not seen, although it was hyperintense on T2 as well as on the FLAIR images. So this was the reporting of the MRI brain, that it has left posterior parietal lobe subcortical T2 FLAIR hyperintense signals with no diffusion restriction or post-contrast enhancement. So this is likely due to changes of gliosis, chronic infarct as a sequelae of prior brain insult. So could be ischemic or cerebritis. So it was negative for intracranial abscesses or metastatic infection. This is the trend of the electrolytes of the patient in the following days. From 31st December till 3rd of January, we were observing continuous rise in the potassium of the patient. So starting from 5.08 to 6.02. And we did search for an alternative cause for this hyperkalemia, but there was only one cause, that we started him on high dose of cotrimoxazole, and patient started experiencing hyperkalemia. So we had to stop the cotrimoxazole and we switched the patient to linezolid. So final sensitivity of the culture was received on 19th of January. And unfortunately, the patient bug was resistant to imipenem. We were giving him, initially we started him off with cotrimoxazole and imipenem, and then later we switched with linezolid and imipenem. But the imipenem was resistant, so we had to change the therapy. And currently, the patient was started on linezolid as well as the ceftriaxone. Again, in the February, patient developed repeated pleural effusion. We did a repeat chest drainage. And currently, this is the chest images of our patient. You can see that his lung capacity has reduced a lot. There is a plaque-like pleural thickening of the patient can be appreciated. Effusion is almost gone, and there is still some pericardial thickening present, but there was no pericardial effusion which was developed. So it's a trapped lung. We did consult cardiothoracic surgery, but he is not fit for the surgery. And currently, our patient is under ID and pulmonology follow-up. So basically, our patient was quite okay regarding lungs, but ultimately, with the help with this bug nocardia, it led to the trapped lung in almost 2 months only. So let's discuss about this topic, nocardia. It is quite rare. It is not seen too much in our practices. It is a branching filamentous gram-positive rod. It is an aerobe and it is a saprophyte. The virulence vector which nocardia uses is mycolic acid in the envelope. It is highly pathogenic species. They basically secrete superoxide dismutase, especially the nocardia steroids complexes. It also releases catalase and it has a tendency to form biofilm. Immunity our body produces against nocardia. The first line immunity is innate immunity, and later it is T cell mediated immunity. Antibody has no role in the immunity against nocardia. So it is ubiquitous in our environment. It is found everywhere. It can be seen in the soil, in decaying vegetations, fresh water, aquatic environment, even in the house dust. It is contaminated with nocardia. Tap water, swimming pools, they have nocardia. So this is a brief classification, current classification of nocardia. It belongs to the phylum Actinobacteria, and the suborder is Corynebacteriaceae, and the family which Corynebacteriaceae has, it's Sucomuralaceae, Nocardiaceae, and Mycobacteriaceae, and Corynebacteriaceae. So in the family of nocardia, we have genus Nocardia, we have genus Gordonia, we have genus Rhodococcus, and Williamsia. Up till now, more than 100 species of nocardia have been diagnosed through molecular as well as the mass spectrometry. And the previously known nocardia steroid complex, it has been reclassified to further complexes and speciation. So previously, our bug was Nocardia seriousi georgica. Previously, it was called as Nocardia steroids drug pattern 6. So now it is present, it is designated as separate species. So regarding transmission, nocardia is present everywhere. So it is inhaled through the lungs as well as it is inoculated into the skin. Risk factor to get this infection is all the immunocompromising conditions like alcoholism, steroid use, immunosuppressive use, especially calcineurin inhibitors, TNF-alpha, those immunosuppressive which reduces the T cell immunity. Organ transplantation has a risk factor to have this nocardia infection. All the kind of malignancy, whether solid or hematological, HIV infections, primary immune deficiency syndrome, especially those involving T cell defects, and exposures, especially this is very important because it is present everywhere in the environment. So we are exposed to nocardia in outdoor activities like gardening and farming. Even insect bites and the roadside accident, skin puncture wounds can be the causative agent to inject this bug into our body. It also has a nosocomial outbreaks. Nosocomial outbreaks have been reported in the past, and which has led to surgical site infections, catheter-related bloodstream infections. Although bacteremia with nocardia is quite rare, and there are infections following cutaneous injections of steroids as well as contaminated because cosmetic products they have been reported. So this is a study which was done back in 2012, and a cosmetic product was given to 8 candidates. Intragluteal cosmetic agent was given, and 7 out of 8 candidates developed intragluteal subcutaneous and cutaneous nocardia infection. So this is a study which basically was done, and it basically showed that nocardia was present in the room air of the patient in the hospital. And in that hospital, 18 surgical site infections and 3 pulmonary infections were reported by the same species, which was basically recovered from the air of the room patients. So how do we present clinically? Can anyone comment? What are the clinical presentations of nocardia? I have mentioned you one clinical presentation, that is pneumonia and lung involvement. So what are the other clinical manifestations of nocardia? So any fellow can comment? Cutaneous lesions, definitely. I mentioned a study that people had cutaneous infection by some cosmetic implant. What else? Brain abscess, yes. Sorry?
CNS manifestation, patient can present like the symptoms of the brain abscesses, fits हो सकते हैं और उसके hemiplegia, focal deficit के साथ present कर सकते हैं.
Can you please say it again?
It can present subacutely like tuberculosis.
Any organ of the body can go on.
Actually, you are not audible clearly. Can you please type in the chat box? Skin lymphadenitis, yes. CNS manifestation, yes. Bone, definitely, yes. Although it is very rare to have osteomyelitis by nocardia, but it is there. What else? Abscess, osteomyelitis, yes. So anything else? So surprisingly, nocardia can involve any part of our body, starting from the CNS to every organ, to skin, to bone, even the bacteremia. Although bacteremia and osteomyelitis and other involvement are there, but there are case reports of the nocardia involvement of the kidneys, of the spleen, of the liver. So practically every organ can be infected with nocardia. So let's move on to the clinical presentation. So cutaneous nocardia basically present usually in the 3 forms. It can be superficial cellitis or abscess, or it can be lymphocutaneous a kind of nocardia, which is also called spirotrichoid, and it can even present as mycetoma. So when the patient presents as a mycetoma, we have to think of other causes of medulla foot, and which includes the mycetoma caused by actinomyces and the eumycetoma, which is caused by the fungus. So it is one of the major differential in case of the mycetoma. So this is a picture of nocardial cellitis. It has resemblance with the streptococcal infection, which we see regularly. So we have to keep in mind about the differential diagnosis of nocardia in such kind of presentation. So this is lymphocutaneous nocardia. So there's a fungal infection called sporotrichosis. So it also presents in a similar manner. So we have to keep in mind that it can be nocardia as well. So this is the mycetoma, and nocardia brasiliensis is one of the most common cause of mycetoma. So mycetoma is basically characterized by destruction of the underlying structures as well, including the bones and the tendons and the muscles. And a certain kind of sulfur granules are basically released from these kind of infections, and these granules are full of bacteria. And these kind of granules are also seen in actinomyces, which is quite similar in presentation to the nocardia, and it also gives sulfur yellow color granules. And in the case of U mycetoma, they are usually black color nodules, and that U mycetoma is caused by fungus. So pulmonary nocardiosis, and among the systemic nocardiosis, we have many presentations, and one of them is pulmonary nocardiosis, and it is one of the most common presentation in systemic nocardiosis. So 80% of the patients who have systemic nocardiosis present with pulmonary syndrome, and the most common organism are Nocardia seriously georgica, Nova, Farsinica. And clinical presentation can be subacute or chronic, and patient may present with productive and non-productive cough, dyspnea, hemoptysis, and fever. And a patient can present with pneumonia, lung abscess, cavitatory disease, effusions, and empymas. So this is the different kind of presentations which we see on CT scans of the patient suffering from nocardia. So here we can see that it is presented as lobar or multilobar consolidation. So it is quite similar to the other bacterial pneumonias which we see. So it can also present as a nodule. So these nodules are usually seen in fungal infections. So nocardia can also produce nodules. So here we have this empyema necessitans, and this empyema necessitans, we can see that the pleural effusion is basically crossing the territory of the lungs and it is going into the subcutaneous tissue, and it is going to cause the empyema necessitans. So we have this cavitatory lesion here. It can also present as a cavity, just like other bacteria, the cavitating pneumonias as well as malignancy. So it can also produce as nodules with internal cavitations, and obviously with pleural effusion, pleural plaque, and pleural thickening, empymas. Although pleural effusion, isolated pleural effusion is quite a rare finding in the case of nocardia. So this is a study which I picked up. This was done over a period of 10 years, and 30 patients were identified. In this study, only 8 patients presented with pleural effusion. And there's another study, it is a Spanish study. It was done over the period of 6 years, and 55 patients were included in this study, and only 4 had pleural effusion. And consolidation was the most common finding in these studies. So 40 to 55% of systemic disease can present as a CNS disease, and even the isolated CNS disease can also be the presenting feature. And the patient usually present as a brain abscess or the brain mass. And there is a mass effect which is seen like headache, seizures, low GCS, focal deficit. And this is the rule that if the patient is having pulmonary nocardiosis, you have to do the brain imaging to rule out the brain infections or the metastatic infection to the brain, because nocardia has a tendency and it has a predilection towards the CNS. So we have to basically look infection over there as well. So other organs which are affected are even cornea. It can lead to nocardia keratitis, and it can lead to blindness. It can even lead to endophthalmitis. Kidneys are involved, liver is involved, spleen, bone, bacteremia. There are few cases of bacteremia reported, but still it is there. And it has a tendency to form a catheter, biofilms on the catheter. So it has a predilection to cause bacteremia. So in the case of diagnosis, we have to suspect nocardia, first of all. The reason is that because nocardia takes some time to grow on the culture. The usual time to grow for the nocardia is 5 to 7 days, but it can take up to 3 weeks to grow. So basically, if we are suspecting nocardia, we have to inform our microbiology laboratory that we are suspecting, so they may keep the culture for a longer period of time for nocardia. On the gram stain, it gives a beaded appearance. So it is shown over here. It gives a beaded appearance on the gram stain, and modified ZN stain is used for the identification of nocardia. The standard ZN stain is not used because it has a low mycolic acid in its cell wall, and we need to have a modified stain to identify this organism. So the cultures are the other methods of identification, and obviously the molecular method, the species identification is done with the help of molecular methods, which can include gene sequencing, mass spectrometry, and PCR. So what about the treatment? We usually start with a single drug in the case of cutaneous disease, and in the systemic disease, if the patient is stable. But if the patient is clinically unwell, and if the disease is disseminated, so we usually start with the 2 drugs. And we then later modify the drugs according to the susceptibility testing. So this is the table which is showing the susceptibility of nocardia to various drugs and the various species. Here I have highlighted two drugs, the linezolid as well as the trimethoprim sulfamethoxazole. And you can see that linezolid is quite sensitive to all the common species of this nocardia, and trimethoprim sulfamethoxazole also quite sensitive. So we usually start with trimethoprim sulfamethoxazole because linezolid carries a long list of side effects like cytopenias and other neuritis. So we usually start the patient with trimethoprim sulfamethoxazole. In the case of cutaneous infection, the dose or usual dose of trimethoprim sulfamethoxazole is 5 to 10 milligram per kg per day in 2 to 4 divided doses. It is given. And if there is mycetoma, and then we have to consult surgery department for the debridement and for the surgery. And once the results are available and once the clinical response is assessed, then we later modify the therapy. For example, if the organism is not responding with the co-trimoxazole, then we will think about switching to another agent. The duration of treatment in the case of cutaneous disease is approximately 3 to 6 months. In the case of lung infection, we usually start with a single agent trimethoprim sulfamethoxazole, but the dose is higher as compared to the cutaneous infection. In the cutaneous, we were giving 5 to 10 mg per kg per day of the therapy, and in the case of lung infection, we usually start with 15 to 20 milligram per kg per day. It is given the divided doses. But if the patient is clinically unstable, so we usually start with the IV co-trimoxazole and we add another IV agent like amikacin, imipenem, or ceftriaxone. This was the scenario which we faced because our patient had a progressive pleural effusion. So along with the co-trimoxazole, we added imipenem on the fourth day of his presentation. So some experts also recommend 2 IV agents along with IV co-trimoxazole in clinical unstable if the patient is too unwell. So basically they start with the 3 IV agents, including co-trimoxazole and 2 other antibiotics. So this induction and a combination therapy is usually continued for 3 to 6 weeks. And then we later assess the patient for the clinical wellness is seen as well as the patient response is seen. And by that time, usually the cultures are available, the sensitivity is known, and then we can switch the patient to a single suppressive therapy to an oral agent. But as long as the patient is unwell, we continue the induction therapy. In the case of lung infection, surgery is done for empyema, effusions, pleural thickening, and approximate duration of the therapy in the case of the pulmonary nocardiosis is minimum 6 months. So later it is decided on the clinical grounds as well as the radiological testing helps us in deciding the duration of therapy. In the case of disseminated disease, by the way, what is disseminated disease? Can anyone tell me the definition or what is meant by disseminated disease?
2 or more non-contagious involved.
Sorry?
2 or more sites of non-contagious sites involved, that is called.
Yes, 2 or more non-cutaneous organs are involved in the case of disseminated disease. So in the case of disseminated disease, we usually start with 2 IV agents. As I already mentioned, what was the similar scenario in the lung infections as well. Again, some experts here suggest starting with the 3 IV agents. If possible, we have to reduce the immunosuppression of the patient because it basically is combat with the help of a T-cell mediated immunity. So it's better, if possible, depending on the clinical scenario, that if the immunosuppression is lowered down, so that we can tackle this infection better. The surgery in the case of brain abscess, if it is large and if it is accessible, so it should be drained. But there is no hard and fast rule to do a diagnostic biopsy of the brain. So if you are having a lung infection and a brain abscess, and the lung infection is documented, so you do not need a diagnostic biopsy for the brain to establish the infection. It is nocardia. So you will treat the case as a case of nocardial brain abscess. So surgery is also offered in the case of pericardial effusion as well as in the case of the visceral abscesses, depending on the scenario. For example, if the patient has osteomyelitis, so the surgery would be done for that osteomyelitis. So once the patient is stable and once the sensitivities are available, then induction therapy is switched to the suppressive therapy, and the suppressive therapy usually contains oral drugs. And in the case of disseminated infection, approximate duration of therapy is 12 months. So what is the outcome and prognosis of this infection? Well, it depends upon the site of infection. So if the patient has a cutaneous infection, it has a very good prognosis. But if the patient has multi-systemic infection, so it will carry a bad prognosis. And it also depends on the underlying immune status of the patient. So if the immunity is good, for example, the cutaneous nocardiosis usually happens in the immunocompetent patients. So it has a very good prognosis, but in the case of immunocompromised patients, they have a poor prognosis. And again, the delay in the diagnosis and the treatment, because I already mentioned that nocardia has to be suspected if you want to diagnose it. So if you do not suspect, you're not getting this diagnosis. So in the delay in the diagnosis and the treatment will definitely affect the prognosis and the outcome of the patient. So the cutaneous nocardiosis has a very good prognosis, but in the case of disseminated disease, there is a high mortality, and mortality range from 20 to 70% in various studies. And the highest mortality is with the brain nocardiosis. So any questions and comments, please?
Seemal, I think there's one question at least in the chat box.
In the chat box, yes, ma'am. Let me see. So how frequent is the pericarditis is not very commonly seen in the case of nocardiosis. It is quite rare. But as we know that pericarditis can be a presenting feature in any of the lung infection, because it can be due to the metastatic spread through the blood, or it can be the spread to the adjacent organs. Right? For example, the left side of the lung is involved, so it can involve the pericardium as well. It is not seen very frequently, but it is there. What goes
Yeah,
to
and
the
mostly we have case reports on this.
yes, ma'am?
I'm just adding to what you're saying is that it is very rare and mostly we only have case reports on
Yes,
pericardial
ma'am.
involvement.
Yes, it is limited to the case reports. Yes. Which goes?
Assalamu alaikum. I have two questions.
Yeah, please.
Muniba, first thing is, how good is ciprofloxacin in treating MSS and pneumonia? Secondly, this patient had hyponatremia with hyperkalemia. So have you can work up for adrenal insufficiency?
Yeah. We actually, when we were facing this electrolyte imbalance, let me go back to the slide. So yes, we can see here that the patient was having progressive hyponatremia as well as the progressive hyperkalemia. So we did take endocrinology on board, and a workup was done to find out the cause for this. So basically, you can see on the 2nd of January, I have mentioned the serum osmolarity, urine osmolarity, and sodium spot test. So these all are suggestive of syndrome of inappropriate ADH secretion, right? So our patient had a brain pathology. I showed in the MRI of the brain. So it was because there was no other reason for this SIADH picture, which was there for hyponatremia. So it was attributed to the brain pathology which our patient had already had in the brain. There are some case report about cotramoxazole that it can also lead to SIADH, but in our scenario, the patient continued to had this abnormalities of electrolytes regarding sodium after stopping the cotrimoxazole. So it was not attributed to the cotrimoxazole. So it was attributed to the brain pathology he already had. Regarding yes, we did a cortisol examination and all the tests were done, and they were not suggestive of any other pathology. So it was attributed to SIADH due to the brain pathology. And regarding hyperkalemia, we did find all the kinds of drugs as well as the other pathologies. RFTs were repeated and every pathology was looked for, but there was no other explanation other than cotrimoxazole. So we had to stop. And once we switched the patient from cotri to the linezolid, the hyperkalemia was settled.
And Dr. Muniba, for your second question, so actually Cipro was very briefly there and the patient was already receiving cotrimoxazole. So the Cipro was for the Pseudomonas initially and not for the MSSA. And as Seemal mentioned, he was on Pipraz initially, then received cotrimoxazole, then was switched to imipenem. That's how the MSSA was.
If the patient is stable, you should give one drug. So,
Okay, thank you so much, and very nicely presented. Thank you.
Thank you, Seemal. That was an excellent presentation. Does anyone from any side have any other questions?
Assalamu alaikum. I'm Dr. Kashif, fellow from SIUT Karachi.
Yes.
This statement that in stable patient we should start from one drug is maybe we don't agree, because here we seen cardiosis most of the time in transplant recipients, in renal transplant recipients. So if when we diagnose, the patient may have some radiographic findings in chest X-ray and sign symptoms and modified ZNR growth. So we start with 3 drugs initially. We don't
Yeah.
start even if the patient is hemodynamically stable. So we don't give one drug. When we see that MZM is positive and clinically and radiographically he is compatible in cardiosis, so we start initially with 3 drugs. So to
Three
say
drugs.
this like that the patient is clinically stable in pulmonary cardiosis, one drug is, I think we should think on it.
Actually, it is, I already mentioned, it is based on the expert opinions. Some experts start with the 3 drugs and some starts with the 2 drugs. It is not, there is no perfect guidelines available up till now for nocardiosis. So basically, it's an physician choice to start with 3 drugs or 2 drugs. As you mentioned that you start with the 2 drugs, but we started our patient sorry, you mentioned that you start with the 3 drugs and we started our patient on 2 drugs actually. So it is not a hard and fast rule to start with 3 drugs. There are some expert opinions and advices.
Well, regarding the initial, as Dr. Kashif said, if the sputum patient has pulmonary nocardiosis, so obviously we need to start a regimen before ruling out if the patient is having disseminated nocardiosis or not. So before going for brain imaging, we start with a combination of drugs, and
Right.
once the CNS extension is ruled out, then we can consider switching or tapering of antibiotic to
Right.
single or maybe 2 drugs.
Right. Thank you. Any other comments, please?
कोई patient is stable दो दिन,
कभी तो सेंसी आ जाती है तो बोले
so it starts with 2 दिन. ये था ना patient clinical stable.
हमारा तीन से कैसे बोलते
Thank you.
हमारा ये इशू होता है कि हमारी हमारे होती है और तीसरे चौथे बच्चे होते हैं.
Thank you very much. Very nice presentation. Afana.
Thank you everyone for joining us. Thank you so much, Seemal.
Thank you. Thank you. Okay.
Get off it.
Thank you. Dr. Asma? Dr. Asma, can we start on-site ID CPC again? If I think she left, so probably I'll call her. Okay, leave it. Thank you so much, Seemal. Thank you.
Yeah.
Okay, Rafet.